Hello, everyone. This is Dr. Sabina Rao, and today I'm going to be talking to all of you about eating disorders from the Indian perspective. Eating disorders is not something that's very common in our country. A lot of people haven't really heard of what it means. And so, as a part of a multidisciplinary team discussion, as a psychiatrist, I will be talking to you on the psychiatric Indian perspective. I think before we go into what eating disorders are and the details and the types, it's really important to understand because as a culture, a lot of our get togethers, our gatherings, our marriages, our ceremonies are based around food. So if you go into a wedding or you go into a very nice reception and the food is fantastic, it's the kind of food you like, and you decide to have 10 parathas or 10 aloo parathas and 5 paneer parathas rather than your usual two, that would not uh, quite meet the criteria for an eating disorder unless you've been doing that for the last 5 years every day. Uh, Jokes aside, eating disorders is a mental health and a medical condition, and it does have a definition. And as you can see on the slide, a feeding and eating disorder is characterized by persistent disturbance of eating and eating related behavior. So the key word is persistent, not a one-off, not when you went for your friend's, bachelor party or bachelorette party. It's more of a form of behavior that's consistent, persistent, regular, and it results in an altered consumption of food and significantly impairs physical and psychological functioning. One of the important things about, and these criteria, by the way, I have got from the DSM-5. ICD-10 would be similar, and a lot of the research that I have been through from the Indian perspective have the DSM in it, so it made sense for me to go through the DSM-5. And one of the common things in DSM-5 is that most disorders are characterized by the fact that they affect somebody's physical, psychological, occupational, and personal functioning. And obviously, in the case of an eating disorder, it's affecting the physical and the psychological functioning. And a physical functioning is significantly impaired to a point where it can be life-threatening. And that's why, as I'm going to go through the small talk, I mentioned that it's important not because it's common, it's important because of its high rates of morbidity and mortality. So I'm not going to be going through the criteria of every single of these disorders because that would take me an hour's talk. I am going to mention the names pica, rumination disorders, avoidant restrictive food intake disorders, very interesting names and very interesting disorders from a mental health and a medical perspective, from definitely the perspective of what dietitians do, I'm sure. Anorexia nervosa, bulimia nervosa, binge eating disorders, and other specified feeding or eating disorders, or others as in the past would be called unspecified eating disorders. What is important is that I can't be going through every single one of this, but I do want to mention pica, which I finished my MBBS in 1999, and during my training, that would be in the 5 years from 93 to 99, we did see in the pediatric ward kids with kwashiorkor and marasmus, which I don't believe, at least not in the metropolitan cities, are these diseases seen anymore. These diseases are almost, at least to a significant extent, not visible to a regular practitioner of medicine or a trainee. So, but in our day, when we were training under different hospitals, pica would become a part of a child or a young adolescent who had anemia. So that was something interesting, which is no longer mentioned. When I go through pica as a part of my research for this talk, I found pica was mentioned under the category of pregnant women who were seeing obstetricians, very, very different from the pica we saw in our day. And by the way, pica is ingestion of non-food substances like brick, mud, dust. I can think of cement, anything that's not actually edible or should be eaten. I'm not going to go into rumination disorders, avoidant restrict. Like I said, that's just immense topics and actually quite interesting topics. So I'm gonna try to stick to the ones that are actually more heard of, quite significant morbidity and mortality, as I mentioned, and quite a great amount of an economic impact on the population. So anorexia nervosa, bulimia nervosa, binge eating disorder are the three that I found a lot more evidence on. Anorexia nervosa and bulimia nervosa, I feel like I need to talk a little bit more about. Anorexia nervosa, I want to mention a few things about the diagnosis, because my understanding is that there are not only dietitians in this group, there are people who are in college studying dietary science at this time. So restriction of energy intake requirements, leading to a significantly low body weight in the context of age, development, trajectory, physical health. The low weight would be defined by the what would be normal for that child or the adolescent. As you probably know, this illness is characterized by young adolescents, usually into the 20s. Of course, you can see it in older women, and in older women, of course, the trajectory is a little bit chronic and probably more severe, but we'll get to that. Another criteria is the intense fear. Now, I can tell you of this cases that I've been seeing in my practice where it's a definite no. If I give you a medicine for depression and anxiety, and it may cause maybe 1 or 2 kgs gain in weight, the immediate reaction of the teenagers, absolutely not. I cannot afford to gain weight. There is an intense fear when this individual says that has a discussion with me about depression and anxiety, and I discuss a potential side effect which may or may not occur, but the fear is real and the fear is intense. Disturbance in the way, if you ask somebody with anorexia nervosa, or which we're talking about right now, if you ask somebody, when you look at yourself in the mirror, what do you see? Do you see a fat person? And they will say, yes, absolutely, I am too fat. And the person standing in front of you is somebody that's incredibly thin. I worked in the eating disorders as a resident in the United States, and we had a group that was running as a part of the eating disorders program. And one of the big things that you noticed was how incredibly underweight these young women were. These were women probably in their 20s, and the weight loss was pretty obvious, but to them, they were still fat. The idea of eating was painful. And then so that was one of the things I wanted to talk about. And then switching over to bulimia nervosa, which again, a reason I'm bringing it up is because among the eating disorders, other than anorexia nervosa, bulimia nervosa is common. And I want to guess that bulimia nervosa is probably more common in our country than anorexia nervosa, because I think I have seen a lot of people with bulimia. When I say a lot, obviously the percentage compared to anxiety and depression is low, but I have seen enough to worry that it's more prevalent in our country, but people are not willing to seek help. I have had them come to me, we have a good session, and unfortunately they don't come back, and I'm not sure what it is. It is definitely the stigma of mental illness, the stigma of eating disorders, and the idea that how can we as a country that's been around for a little over 70 years wrap our heads around the idea that somebody would not eat when food is presented to them and food is in abundance. The idea, the concept itself is overwhelming, and it may be very hard for the lay public to understand that concept. So that's what I feel makes it very stigmatizing. Now, when bulimia nervosa as an illness, and I'm not going to spend too much time on the rest of the eating disorders, and I'm not going to spend too much time on criteria. This is the last one. It's an episode of discrete eating, and the quantity that's eaten is significantly larger than what is normally consumed. This can go into thousands of calories. Please understand, thousands of calories. And the difference between bulimia nervosa and binge eating disorder, which is also in the DSM-5, which was recently included, I believe, in DSM-5, is that in bulimia nervosa, an individual then tries to bring it out, purge, use diuretics, use insulin, use laxatives, and all other forms of bringing out the food that they feel extremely guilty about consuming. And of course, just like anorexia, there is a lack of control. And in bulimia, it's a lack of control over the incredible amounts they have eaten. In anorexia, it's a lack of concept that there is an issue in the body. Recurrent inappropriate compensatory behaviors, like I said, misuse of laxative, diuretics, medications, fasting, excessive exercising. These will be individuals that will exercise for over 2 hours at the detriment of their physical and, of course, physiological health, and, of course, at the end, mental health. I want to say that it would be commonly seen in some sports people. I'm not saying that it is common in all sports people, but especially in the female sports women, in the sports women, it would not be unusual to see some form of an eating disorder where it is obviously a requirement to be fit, but for the woman, it's also important to look as good as she wants to look. So it's a bit of a challenge for them. Now, to talk to you about the binge eating disorders, is it at least occurs once a week for at least 3 months. And of course, you have the mild, moderate, and the severe, one time a week, 4 times a week, and the numbers go up for depending on the severity. Self-evaluation is unduly affected, as would it be in anorexia, and the disturbance doesn't exclusively occur during anorexia nervosa. Now, coming to the Indian context of eating disorders, I would say this was a challenging topic for me, and this is not the first time I've given a presentation, but challenging because there is not much data out there on eating disorders. You can look up any eating disorders. At least in anorexia and in bulimia, you will find some data. But talking about pica or other forms of restrictive eating disorders, I don't think I would easily find much data. So that's my first slide. As far as the Indian data, rare and almost absent in India. I have to agree because there was a big study, and I'll talk about that from NIMHANS, which is in Bangalore, that showed the same. It is interesting at the same time that there was a study that mentioned a 1992 article that mentions that it is rare, but it is increasing. And so even as of 3 decades ago or more, the physicians that have done the study felt like that the eating disorder numbers were going up. At the same time, as you go back to 2016, you find that data is still lacking, despite many psychiatrists that have been surveyed having said that they have seen at least one case. I was talking to my colleagues across the country about how many people have seen eating disorders, and there was a colleague that mentioned, I've seen about 5 to 7 a year. And I want to say, even for me as a practicing psychiatrist, that's as many as I'm seeing. It may be interesting to also note that in India, it's possible that we are not asking about eating disorders. We are not asking about eating disorders as much as we probably should. It could be that the adolescent and child psychiatrists are asking more than adult psychiatrists, but as an adult psychiatrist, I am seeing young women. I am seeing young women 17, 18, 19, 20, where eating disorders is meant to be, is quite prevalent. Yet, it makes me wonder as to how many of us in second tier, third tier cities of India are asking about it. It's not a new disorder. It's been around for centuries. But it makes you wonder if it is a Western influence or what it could be, which I'm going to bring up again. As I said, the study by Preeti Jacob et al. From NIMHANS showed that in a study that they did at the outpatient department of the child and adolescent department, 0.063%, a very small number. I think they surveyed the files of quite a few, and they found eventually 12 cases they were able to report on that met criteria for an eating disorder. I also want to mention that eating disorders is rarely in isolation. Eating disorders comes as a part of OCD, which is obsessive compulsive disorders, anxiety disorders of other kinds like generalized anxiety disorder, social anxiety disorder, phobias, and depression. Of course, you will have a chunk of population with eating disorders definitely struggling with depression. And that's when the conversation on, do you mind if taking a medicine that'll help you? It might make you gain a kg of weight, and then it becomes a challenge. So coming back to the little mention I had earlier, is there a Western influence? Are we talking about eating disorders today because our society is suddenly influenced by the West, and there is so much social media exposure that every kid now has access to Instagram, to Snapchat, to basic Facebook, and there is this barrage of information for teenagers about what an idea of a good weight or a good body image should be. So it makes you wonder if that is, and I say it makes you wonder only because I don't have the data to suggest that the Western influence is responsible for us having eating disorders. There is in fact data to the contrary which says socioeconomic status does not make a difference. That brings me to the point of ascertainment bias, big word. What it basically means is people like us even living in the West, including Latinos, Afro-Americans, and the Asian population, which I would say we are maybe a part of, tend to seek mental health care less than a Caucasian person. So that also could be responsible for us not having enough data about our race and ethnicity of people. And of course, the important thing that I want to bring up in the last couple of slides is that as an illness, whether it is Western influence, whether it is how society is meant to be now, whether it is the recurrence of a disease that's centuries old, I don't know the answer to that. That could be a philosophical, anthropological discussion. But as far as I know, for whatever it's worth, it's an important disease to think about. And here's why. High morbidity and high mortality, according to the DSM-5, 12 per 100,000 per year of suicide risk, crude mortality rates. And that's the other thing. Most of these eating disorder studies looked at crude mortality rates or did not, the studies were not strong enough to get included in many of the meta-analysis, even done abroad. Even adjusting for socio-demographic factors compared to other mental illnesses, 5 to 6 times increase in risk of suicide attempts. So this is a very serious disorder. This is a very serious disorder. The risk of, the numbers are low. And in fact, anorexia nervosa, I believe, has the highest rates of suicide in any mental disorder that we treat as regular psychiatrists. So what do you do? I mean, with all these doom and gloom information that I'm giving you, what do we do? What does one do to help somebody with an eating disorder? It's usually 5:1 female to male. So yes, you will see a lot more females than you will see males with eating disorders, but that does not mean that males don't ever get a disease like eating disorders. But certainly females are higher, as are depression and anxiety. I just do want to mention the fact that the economic burden of this disease is tremendous. And that is why even the treatment plan has what I've written is I've written multidisciplinary approach. Location of treatment could be inpatient, partial hospitalization, residential program, outpatient. Watch out for refeeding syndrome. Watch out for fluid overload. Now, what does this bring to my mind? When I think about this, and I have practiced in the States where either you have insurance, which therefore you will be treated, of course, unless you go to the emergency room, which whether you have insurance or not, you do get treated, or you could visit a community mental health center, which doesn't cost you that much. But most people have insurance and would like to have insurance, and the cost of eating disorder treatment in a residential facility can be phenomenal, because sometimes they have to stay for weeks, sometimes for months. Look at the multidisciplinary approach: a dietitian, a psychiatrist, a psychologist, an endocrinologist, a physician, that would be an internist, and a gastroenterologist, and whoever knows what. And why do we need all these people? It would be challenging to discuss every single symptom of anorexia nervosa, but just briefly, BMI below 18 carries. Then you have the electrolyte imbalances, especially phosphorus, dehydration, significant emaciation to the point, like I said, BMI could be 16, it could be 15. This person would need an admission to a facility, would have to be monitored carefully and slowly. I've mentioned refeeding syndrome. So just like in the wars where when people were starving and suddenly you give them a bunch of chocolates to eat, they actually died. So you have to be very careful. And the physician treating somebody with eating disorders should know what they're doing, because they don't want to overpump them with fluids or food, which may result in mortality. So eating disorders, if you even look at these 3 slides, you realize that this is economically a burden to any country that's treating it. It almost matches the amount of money that is required in the treatment of anxiety and depression. So that was a surprising fact for me. So that's about all I have for you today on eating disorders from a psychiatrist's Indian perspective. I have put up some links for you all to see in case you want to go through. This is articles that I mostly found on the internet. A lot Indian articles are freely available. Indian Journal of Psychiatry has a lot of articles and it's always free. So please try to see if you would like to visit these articles. DSM is also available online through different forums. And that about ends my talk. Thank you for listening.